Okay. Thank you very much to the organizers for giving me this very interesting topic and making me part of this excellent academic session. Red herrings in fever etiology. So I'd like to start by a disclaimer. I'm certainly not an ID expert or an academician to be with the panelists that I've just heard exemplary talks. I'm, after all, a pediatric intensive with some working knowledge of infections and a slightly better knowledge of the deranged physiology in ICU. With this background, I would just like to go through few cases which we came across in acute critical care, where we did come across red herrings in reaching a diagnosis and the learning points after each case. I use 5 filters to come to an etiology in critical care. The first and the most important filter being the history and the clinical examination. However much we think that it's investigations, it's the fancy monitors, it comes back to only history and clinical examination. Yes, with backup of investigation, our next filter, and one of the most important filters in acute care is reassessment, how the child is actually responding to the medications. Also, what the parents feel takes a lot of precedence. And finally, our gut feeling. If we think this is not right, it's probably not right. So the first child is a 4-year-old girl with 8 days history of fever, progressive lethargy, and poor feeding. She was admitted in an outside hospital, noted to have a very low hemoglobin, tachycardia, developing shock. She was given ceftriaxone fluids and supports, but once they saw her hemoglobin being so low, they urgently shifted to our PICU. She was definitely tachycardic, low saturation, impending cardiac arrest with low blood pressure. She had severe pallor, mild icterus. Her chest was clear, but she had all the features of shock with a dropping blood pressure. She wasn't giving us much time. She was acidotic with a very high lactate. Her hemoglobin, which was 5.4 in the outside hospital, by the time she reached us 3 hours journey, was 2.7. We knew there was some sort of active hemolysis. Total counts were very high. CRP was high. Bilirubin was high. She was coagulopathic. Features of multi-organ dysfunction. Her DCT was strongly positive that the lab actually called the emergency and mentioned it. She had bilateral X-ray infiltrates, probably pulmonary edema, mild cardiomegaly, LV dysfunction. Now we have a sick child who was anemic, who was previously completely well and getting worse, developing shock and features of sepsis. We did all the tropical infection screen, which came negative. So we thought there is some sort of sepsis with secondary hemolytic anemia and shock. We started her on the same ceftriaxone, but then realized that she was way too sick. We started meropenem, added vancomycin, doxycycline, and azithromycin. As we know, when we are at the end of the spectrum, we don't have much time. So we hit it hard for atypical cover, tropical infections cover, as well as gram-positive and gram-negative. We also gave her steroids as per the hematologist advice before giving her the transfusion, and had to intubate her, do the usual fluid resuscitation as well as inotropes. Now, this was the little girl on the ventilator. Her chest X-ray after intubation and now opening up the lungs looked a little better. But she continued to have raging fever. She tolerated the blood transfusion well without any massive hemolysis. We could not come to what could be the cause. Her cultures till then on day 2 was negative. Her CRP, of course, was coming down. So we thought we are on the right track with the antibiotics. We also added clindamycin in case there was a component of a toxic shock. And because her shock was still not fully better, but the rest of the clinical parameters were inching towards normalcy. However, the fever was still there. Now, with persistent fever on day 4, and initial cultures not showing anything, we had to do the last thing which we do in the ICU, which is add colistin, thinking of some sort of resistant bug. And that's when we sent a repeat blood culture. On a delayed growth on the primary blood culture, we actually got Klebsiella, which was carbapenemase resistant organism. If you look at the sensitivity, it was actually sensitive to doxycycline, cotrimoxazole, and gentamicin. She was on doxy already, but was not fully improving. So at this stage, we started meropenem, colistin, and gentamicin. All her clinical parameters started getting better. CRP started becoming better. Her hemoglobin was holding on. There was no further hemolysis. but her fever did not go. So we removed all the lines, changed the cannula. Still, the fever was there. And as Dr. Kukreja had so beautifully pointed out about drug fever, we thought when everything is getting better, it's probably drug fever. We were so tempted to stop everything else, especially since by day 5, the parents had exhausted their resources and said, look, our child is much better. We want to go home. But the gut feeling did not let us. Klebsiella, which was carbamazepine resistant, are we missing something? So I forced them to do a molecular diagnostics. And that's when we got the carbamazepine resistant organism, which was NDM positive. Now that clearly tells us that they won't respond to colistin. We had to start ceftazidime, avibactam, and aztreonam. We stopped everything else. This was her looking very, very well in no time and no fever, making a card for the whole team. And she was discharged with normal ejection fraction and on follow-up, no further hemolysis. So what was our learning point? Even when all the labs and clinical parameters are improving, if the fever still persists, we cannot ignore, especially when we have a resistant bug. So here we use the filter of reassessment and, of course, our gut feeling. Case 2, a 1-year-old child with history of waking up in the morning with increased phlegm. She had a fever of only a day, but she was noted to have breathing difficulty and profuse nasal discharge. She was very drowsy, taken to a local center where she had a convulsion, thought to be febrile seizure, and then referred. Apparently, child was completely playful till the previous day evening. So this was her. She had a temperature of 99. Her blood pressure was okay. She was saturating well, but she had severe encephalopathy, lot of secretions. Her GRB was okay. She also vomited and finally got intubated in the emergency itself. Interestingly, she came during the COVID phase where she was COVID positive. Now, we thought, could this be one of those rare presentations of acute COVID, which is described in the literature? All our registrars and team got very excited. Could this be something which was causing encephalopathy? So we urgently did an MRI brain, which was strikingly normal. Now, we had a child with severe respiratory distress, but an X-ray which was normal, hardly any oxygen requirement, so we decided not to do her CT chest. She also had severe altered sensorium, which was not explained. And if we look at the inflammatory markers, they were all normal. Her organ function was also normal. Are we missing something else? What was really striking was the profuse secretions that she was having. And I looked at her pupils, which were pinpoint. I don't know if you can actually see it. It was actually pinpoint. This was very striking. We revisited the history and asked the parent, was there any possibility of exposure to a fertilizer? By this point, they thought we don't have a clue of what we were doing because we had just told them of COVID positivity. They were extremely upset seeing the child intubated and they thought they're going to lose the child. So I had to sit down and tell them there is a toxidrome, which I'm thinking about. Think about anything that they did with a fertilizer exposure. And they vehemently denied. The only history which came up was they had moved to the house only the previous night. 7 days they were outside the house. And I asked why. Well, they said the house was being rigorously cleaned by a pest control person. I said, what was the agent used? And they did not know. So we actually called the pest control guy and asked him to send the picture of what he used. And clearly it was metacid. It was one of the OP poisons. So then we did an atropine test and she actually passed the test where she did not have any pupillary changes despite a high dose of atropine. So we sent a cholinesterase level. Now, is this an unusual COVID presentation or simply OP poisoning? The bloods were normal, organ function was normal, normal CRP. So we decided to simply treat her with PAM, atropine, and see what happens. Within 6 hours, we got a cholinesterase, which was almost undetectable, less than 10% of normal. We had a diagnosis and in no time she was home. So what really happened was this was a crawling child. There were pieces of the pest control powder which was left about in the house. When they went back, they found all the powder. There were 3 other children. So we decided to clean the house properly and the family were extremely grateful. So the learning point, COVID positivity is not a diagnosis, especially during a pandemic. COVID could probably be a bystander. We need to think when there is an unusual presentation, history and clinical examination was very important, reassessment, and of course, the gut feeling. Next case was a 1-year-old child who again presented with fever, lethargy, and altered sensorium. Now, this child came in severely hypoglycemic to our neighborhood hospital, was given glucose correction, and subsequently presented to us looking extremely sick with severe metabolic acidosis. The initial blood gas had a pH of 6.9 and severe shock and anemia. We had no idea. The child was completely well, had mild developmental delay, but otherwise okay. And it was an breastfed child who was just in the 11th month. We did the fluid resuscitation, bicarbonate infusion, but the acidosis didn't improve. We had to go to peritoneal dialysis. Again, this child was RT-PCR positive. Now, by now, we understood that RT-PCR positivity did not mean anything. The child was very sick, and we had to just treat the deranged physiology. Now, this child being well before this, one of the things which come to our mind is definitely an IEM. Is this a metabolic syndrome? The parents were not consanguineously married. There was nothing to suspect the IEM for 1 year, and then this catastrophic presentation. This was the child having the dialysis in our emergency. But we looked again. The child definitely had these striking features. And I know you're thinking of what I'm thinking as well. We saw very dark toenails, beefy red tongue, very black knees, and this was very different from the parents. When I took the history again and said, could you tell us what you did differently in the last few months? And she said, nothing at all. The child had an episode of diarrhea, vomiting in the last few days, was on nothing excepting breastfeeding. And the mother's diet, I just happened to ask in passing by, although we had so many things to deal with in the emergency. And she says she recently became a vegan and was on a completely vegan diet. That's when it hit a bell. Anemia, severe acidosis. We sent to vitamin B12 levels, which came completely undetectable. We gave vitamin B12 as part of the metabolic cocktail as well, along with fluids and peritoneal dialysis. But what we saw was a dramatic response. This child, within the next day, was sitting about, still the dialysis catheter sticking out of him, but made a complete reversal. And literature search then showed us that severe vitamin B12 deficiency can present this way. And in no time, the child went home. So learning point here is a thorough clinical examination with an open mind is important even in emergencies, especially with unusual presentations. Always talk to parents if they were doing something different, like an unusual diet, or even started with new drugs like alternate medicines. Here, the history clinical examination filter, as well as the parents, gave us the clue. The next case is a 3.5-year-old girl who presented with a fall from a cycle. She complained of back pain following the fall, but seen by a local orthopedic surgeon and reassured after X-ray, said the spine is normal. Thereafter, the child the next day developed fever. She was seen by a local doctor, GP, who had noticed cold and cough, started Augmentin and Ibugesic. The child was well for 3 days, but then restarted with fever. By the time she presented to us, she was febrile, toxic, and in early shock. There was no focus of infection. My registrars was very clear. The chest was clear. Abdomen was normal. Limbs were normal, and there was no rash. The child clearly had sepsis with shock, and investigations were congruent with that, with a high total count, high neutrophilia, lowish platelets, high lactate, very high CRP. And the urine showed pus cells positivity, which was not dramatic. It was only 8 pus cells. So we thought, okay, this is a probable UTI with pyelonephritis. However, the ultrasound was normal. Our working diagnosis still was urosepsis with shock, so we started ceftriaxone and amikacin. We expected her to get better in the next 48 hours. However, she continued to remain toxic. She had fever spikes, she went into capillary leak. Her repeat counts on reassessment showed her total counts were 22,000, further increase in neutrophilia and a CRP. And now we thought this is high time we do the LP. That's when, because we've ruled out all other foci of infection. When we considered LP, we actually looked at her back and she kept saying she had back pain. And then it occurred to us that it was tender in the lumbar area. Are we missing anything? So we went ahead with an MRI spine. And there was clear-cut paraspinal abscess. We ruled out TB, started her on ceftriaxone, vancomycin, and after completing 14 days, she did not require removal of the pus. With antibiotics, it melted and she made a complete recovery. So our learning point here, parents usually relate events to a recent trauma. The trauma was trivial, it was incidental. She actually all the time had a paraspinal abscess. We don't know why she developed that. Back pain in a child is extremely unusual. So if it is present, we need to relook and look again and reassess every time. If not following the usual path, look for an alternate foci. The next case is an interesting adolescent girl who was 15 years, weighing 68 kilos. She presented with fever of a week. She also had headache and vomiting for 3 days. She was from the Tumkur belt. She received IV ceftriaxone and amikacin for 4 days at the local hospital. And because her fever, her headache did not get better, the parents then transferred her to our hospital. There was nothing else in the history, no recent travel, no contact with TB. The child was otherwise well. One thing which the parents were concerned about is they said she had gained 4 kilos in the COVID times, and she was just sitting and preparing for her 10th standard exams, which was due in the next 2 months. And she was otherwise a completely well immunocompetent child. When we examined her, she definitely had a board-like neck stiffness, but her sensorium was normal. She did look very tired, lethargic, and febrile. We did an urgent MRI, which was normal. Her hemoglobin was lowish. Her total count was okay. Not much neutrophilia. CRP was mildly positive. Electrolytes, liver function test was normal. We went ahead with this CSF study, which showed 110 cells, 10% neutrophils with a high protein and sugar low. So all this was fitting into a partially treated bacterial meningitis. We were happy with our diagnosis, started on ceftriaxone and vancomycin. Now, day 3, the fever persisted. The parents were behind us that they did not have insurance and the costs were building up. They said the child is still looking dull and vomiting despite anti-edema measures. 3% NaCl was also given. So we upgraded to antibiotics to meropenem and vancomycin. The CSF and blood cultures came as no growth. Fever was there and the child was simply not looking fully right. So we thought, could this be tuberculosis? Well, there was only an 8-day history of fever. She was an obese child. She had a recent weight gain. There was no contact. She was immunocompetent. Only 10% neutrophils were there in the CSF. Everything was screaming as partially treated bacterial. MRI also being normal. Chest X-ray was normal. So we reassured parents that the child may take some time. It should resolve and she should start getting better. And we also shifted her to the ward. The next day when I came for rounds, I had a mini heart attack. The child clearly had false localizing signs. She did not look right. She had a 6th nerve palsy. The mother said she started drooling, so she had lower cranial nerve palsies. Now it was screaming that we were missing something, and it's most likely to be tuberculosis. So we convinced them for a repeat LP. The cells had increased, her protein had doubled, all of them were lymphocytes, and the gene expert was positive. We started her on steroids, 3% NaCl, ATT, and she made a complete recovery. This girl was a fighter. She actually wrote her board exams, did well, and studying to be a lawyer. So TB will remain a differential for all infections not responding in India. And so we need to keep our eyes and ears open. However, when not showing the expected improvement, as always, we think of an alternate diagnosis. The next case, this is a 2.5-year-old child who actually had a fever for 7 days, was not investigated. Father was known to be COVID positive a month ago. So they thought this child has probably something related to COVID. They were from the outskirts of Bangalore, rural Bangalore. The child became progressively drowsy, then developed rashes. In villages, they say these rashes are normal, so they did not show anybody. But then the child started developing distended abdomen, puffy face and eyes, looked more sicker, did not take feeds. That's when the child went into status epilepticus and had seizures, shock, had a respiratory arrest, and finally reached our hospital. Was given 3 anticonvulsants, was intubated, fluids, inotropes, the whole works. The child had an extensive petechial rash all over the body, strikingly on the palms and soles as well. And there were few discrete lesions also. There was anasarca, there was a large liver spleen, and MRI showing meningeal enhancement. We stabilized the child, went ahead with doing a septic screen. Everything was positive in the septic screen, including LDH, D-dimer, and ferritin. The troponin I at that time was also high. The child was persistently tachycardic. So Looking at this child, we thought this is straightforward rickettsial encephalitis with status epilepticus. The child should improve with meropenem as well as doxycycline. And we started the same. We had evidence of coagulopathy and multi-organ dysfunction. The wheel Felix came as positive, higher than 320. So we said we are on the right direction. We also went ahead with an LP on the second day, which showed 35 cells. So we started Miro, Doxy, and Banco was added in case of any secondary infection because the child had gone to 2 other local hospitals and taken some sort of IM injection. The child did not recover the way we expected. The echo done at that stage was normal. Now, considering very high inflammatory markers, we did an echo in case this was anything to do with MISC, but it was normal. Now, the shock did not improve fully. It persisted with edema and leak and the multi-organ dysfunction syndrome. So we kept in mind that this could still be MISC, and so we gave the IVIG and later the steroids. Within 24 hours, the child was extubated, did dramatically well, and all the inflammatory markers reduced. Well, was this MISC or was this a tropical infection? We saw the literature, there was a lot of overlap, and spoke to our PICU colleagues. They were also dealing with a similar situation where at the peak of MISC, we also had tropical infections, which was probably triggering it. So we had to treat both. The child on follow-up did well with a normal echo. So here our learning point was tropical infections are most common in India. We do treat them, but we're not showing expected improvement, especially with the recent COVID exposure, multi-organ dysfunction. We had to keep MISC in mind and treat for the same. So in summary, we need to apply all 5 filters each and every time we approach a child with an unusual presentation or an unexpected response, or even when the values of clinical and investigations are incongruent and do not match. We always need to be ready to question and revise our diagnosis. Thank you very much for your attention.